very pertinent clinical and surgical anatomy. To begin with, okay, patella, as we know, this is the largest sesamoid bone. This has actually medial facet and a larger lateral facet. This is divided in the midline by a vertical ridge, the thickness of which is approximately 7 millimeter. So the cartilage in the vertical ridge in this portion is as thick as 7 millimeter, unlike in other points. And lateral facet is larger in 65% of the cases only. In other cases, medial facet may be larger or they may be of equal sizes. And these facets are further subdivided by the horizontal ridges into 7 facets, one more being here, that is the odd facet. These odd facets in the terminal degree of extension, this comes in contact with the medial condyle. This is the posterior surface, and this is the anterior surface. The anterior surface, the important point to understand here, remember here, is the attachment of rectus femoris. Unlike other muscles of the quadriceps femoris, the rectus femoris attaches not only on the base, but also on the anterior surface of the patella, extending up to superior 1/3 of the anterior surface of the patella. This knowledge is important, especially when we are reconstructing the ligament around the patella. Another important aspect here is the patella undergoes some anatomical variation, and that the classification has been given by Wiberg. The patella, this is the medial facet, and this is concave here, unlike the lateral facet here. But these are equal in size. This is type A, again concave, but a smaller medial facet, type B, and almost vertical medial facet is type C. These are also responsible for recurrent patellar dislocation. The excursion of patella is very interesting. As we extend our knee, near terminal extension, the patella tends to go not only proximally, but also laterally. That is because of the direction of the pull of the quadriceps, which is slightly laterally. So it tends to displace laterally. This is quantified by a term called Q angle. This is this can be achieved or measured clinically. Sometimes this tuberosity moves slightly laterally. This is the tuberosity, as in the case of external rotation of the tibia or external torsion of the tibia. In this case, the Q angle becomes slightly increased. That means the direction of the pull of the quadriceps is outwards and more lateral. That makes the patella vulnerable to dislocation. That is especially the lateral patellar dislocation. Now, how this is quantified in the CT scan? This is the CT scan axial view of the proximal tibia, and this is of the distal femur. And this can be overlapped by a CT technician if you ask them, request them to do so. And this is the overlap view. These two sections, different sections are overlapped to obtain something like this one. And then a perpendicular is drawn to a line that connects the posterior aspect of the femoral condyles. And another perpendicular is along the tibial tuberosity. This is called trochlear tuberosity, trochlear group distance. This is approximately 20 millimeters. In case of external tibial torsion, that is the green line moves more laterally, and this 20 mm may become 30 mm or 35 mm. That means the Q angle will also be bigger, and the patella tends to subluxate laterally, leading to patellar dislocation. This is one of the important bony factor for patellar dislocation. Others are genivalgus, anteversion of the femur. These are not as important. Now, this trochlea is again very interesting to understand the anatomy of trochlea. This is the lateral condyle, lateral femoral condyle. The articular cartilage on the lateral femoral condyle is higher, more superior here, as in the sketchy picture, and this is more inclined here. This is the lateral condyle, this is the middle condyle, this is more inclined. That is why during full extension, the patella, even if it tends to go laterally, this is stopped, limited by the anatomy of this lateral trochlear facet. And these are sulcus terminalis. These are the limitations of the trochlea. This is actually trochlea. This is the surface with which the patella articulates. And then this is the trochlear group. This is again slightly laterally oriented. So this again defines the track of the patella. This is from lateral, slightly towards medial, proximal, and again then laterally. During full flexion, this is the outer facet that comes in contact with the femoral condyle. So as you can see very clearly here, the small area of the cartilage comes in contact with each other. So there is maximum pressure in this area, leading to chances of posterior arthritis. That is why we advise patients not to squat or cross-legged, because of the pressure is as high as 7 times the body weight. And as we extend our knee, suppose at 120 degree, it is still the intercondylar knots that provide the stability to the patellofemoral joint. And at 30 to 90 degree, the patella sits right on the trochlea, So the bony stability is provided till this point by these two factors, that is trochlear anatomy and the anatomy of the condyle itself. Sometimes the patella is so high at this point, normally during full extension, it reaches so high that there is no more bony factor here to prevent lateral dislocation of the patella. That condition is called patella alta, and there are actually several other indices to find out patella alta or patella baja, or the exact position of the patella. Cadent distance ratio being one of the important one. And another handy method is to draw a Blumenset line. It approximately passes through the apex of the patella. That means the position of the patella is normal. If it is way higher, then the chances of dislocation is still there. So what if the anatomy of this trochlea on the lateral aspect undergoes some variation, normal variation? So this is normal one. And then this is the lateral femoral condyle seen on the X-ray true lateral view by this line. And the green star represents medial femoral condyle. These are actually overlapping with each other. That means this is a true lateral view. And this red mark indicates the trochlear sulcus. If you note it very carefully, the red mark is, this line is going all the way and exiting above the femoral condyle. So that is what should be present in normally. But in some cases, as in this case, this is the lateral femoral condyle. This is smaller and less inclined as compared to the medial femoral condyle. So this is no more going to resist the lateral patellar dislocation. This is because of shallow sulcus. The sulcus angle here in this case is more than 145 degrees. So this is one of the factors for lateral patellar dislocation, and this is trochlear dysplasia type A. If you compare this is normal picture, this line, this is the line for sulcus, this is crossing through the condyle. This should have gone all the way up to here, this point, but this is crossing through the condyle. So this is not desirable. That means the sulcus is quite shallow, trochlea is shallow. So this is type A trochlear dysplasia. This is very important to address for dislocation here. And then this is type B trochlear dysplasia. Crossing sign is present here. On top of that, spur is also present. And this femoral condyle is flat. In some cases, this may be convex. And this is type C here. On top of that, this is lateral femoral condyle. This looks way posterior. That is because of the hypoplastic lateral condyle. So this is, of course, is not going to prevent the lateral subluxation. This is again not desirable. Crossing sign is, this is called double contour sign. This is for lateral femoral condyle and this is for the medial femoral condyle. Crossing sign, of course, is present. This is type C. In type D, again, crossing sign is present. Spur is present. The spur again pushes the patella laterally. This is type D trochlear dysplasia. This was actually given at Dijon et al. If you look at the radiography, normal radiograph, this is the line for sulcus. This is going all the way and then exiting above the condyles. This is normal one. Okay, this is the normal one. And in this case, this sulcus has gone all the way and exited from the condyle. This should have gone up to here, to this position. But this has come away from the condyle. So this is crossing sign. This is called crossing sign. And then the two condyles are asymmetrical here again. This is again, crossing sign is again present here. And both the condyles are hypoplastic. So these are the several examples of trochlear dysplasia as seen in the normal X-ray. What about the soft tissues? There must be some other soft tissues that stabilize the patellofemoral joint besides the bony factors. This is the lateral view of the knee. This is medial patellofemoral ligament, this green line, and this is the medial patellotibial ligament. This medial patellofemoral ligament accounts for approximately 60% of the stability, while the medial patellotibial ligament accounts for 20% of the stability. And they have their lateral counterparts respectively. And this is the medial collateral ligament. And some fibers of the MCL, superficial fibers of the MCL, converge with the MPFL, while other fibers of the adductor muscle, adductor tendon also converge with the MPFL. So sometimes this tendon may be helpful in reconstructing the ligaments around the knee joint as well. And this is vastus medialis obliquus, another important soft tissue stabilizer. This is at an angle of 55 degrees to the horizontal. So this is almost transverse, thereby providing the medial lateral stability to the patella. Again, it's important to understand the attachment of the MPFL. This is on the superior 2/3 of the medial surface of the patella, while on the femur, this is a saddle here. This is saddle-like groove in between the medial epicondyle and adductor tubercle. So this is the attachment of the MPFL. This has been quantified by so many millimeters above proximal and posterior. But in a simplified way, this is between medial epicondyle and then the adductor tubercle on the middle aspect of the femur. And other stabilizers quadriceps tendon proximally and patellar tendon inferiorly. When we contract our quadriceps tendon, the patellar tendon is also at the same time pulls downward. So the joint reaction force, resultant force is towards the posterior aspect of the femur. Thereby, the patella is stabilized. This sits on the sulcus because of this joint reaction force. So these are equally important in case of quadriceps dysplasia. Again, there may be patellar dislocation. And as we extend our knee, this is the picture in flexion, approximately 30 degrees. Well, this is a picture in full extension. If you look at the MPFL ligament here, medial patellofemoral ligament, this is slightly oblique. So as we tend to extend our knee, it becomes more oblique. This can be compared with a guide rope. This is a guide rope here, and this is the patella. As we extend, as we move this point more proximally, more higher, then this rope tends to be tighter. Similarly, the MPFL tends to be tighter as we fully extend our knee. Again, it stabilizes in this way, not only the medial, but also on the lateral aspect. So this is the guided concept of soft tissue stabilizer. So these are soft tissue stabilizers, the ligaments, quadriceps tendon as well, vastus medialis obliquus. And then capsule also provides some stability to the patellofemoral joint. So the patellofemoral joint the anatomy can be better studied in terms of the bony factor and the soft tissue factors. The bony factor, trochlear dysplasia is considered one of the most important bony factor, while out of the soft tissue factors, patellofemoral ligament, there are two, the medial one, that is the MPFL and trochlear dysplasia are considered the important factor for patellofemoral joint stabilization. This is a very brief clinical and surgical anatomy of the patellofemoral joint. Thank you very much indeed.